He'll be presenting his experience using surgical theater synchronizer and the use of real augmented reality in the operating room. Please take it away, Dr. Lewis.
All right, thanks, Sonny, and welcome everybody. We're going to be we're taking a bit of a journey today. You guys saw the F-16 fighter pilot missions there. We're going to be talking about how, just like fighter pilots, we use virtual reality to plan and rehearse for surgery, and then taking the same technology into the operating room, we use augmented reality to make surgery safer and more effective. So we're going to be starting off with how we plan and rehearse for surgery. Prior to the development of virtual reality, surgeons really didn't have a method to practice for surgery. In fact, in his book, Skill, orthopedic surgeon for the New York Yankees, Chris Ahmad, talks about the necessity of practice in order to continue getting better and better at what we do. Professional athletes like Michael Jordan, once they become professional, don't stop practicing. They continue practicing 5 to 7 days a week. Whereas we as surgeons, probably because we also have big egos, stop practicing entirely. We just have games. We just operate. We come in, we have game time or operation surgery day, and then we go into clinic. Maybe we go to a course once or twice a year to refine our skills, but we don't have a regular way to practice surgery until now. So I'm going to demonstrate the importance of surgical rehearsal in how we used it to change the surgical plan for one of the cases that we did, and then demonstrate how that technology is used throughout the patient care continuum. So you can see up here on the images, this is a DICOM, standard DICOM images, and you can see this patient had a clinoidal meningioma on the right side, which was pushing on his optic nerve and causing visual loss. So based on the DICOM images, my original surgical plan was to do a supraorbital eyebrow keyhole craniotomy, sneak underneath the frontal lobe, and take out the tumor. But that's what I consented the patient for, that's what I told him I was going to do. Except when we got to the morning of surgery, I put on the VR goggles and did a rehearsal, and I realized that I wasn't going to be able to get the correct line of sight to all of the tumor, and therefore I was not going to be able to complete the tumor resection to get a gross total resection. Well, it doesn't exactly instill confidence in a patient when you tell them, you know what, we were going to do this and we decided to change plans the morning of surgery. They don't really like that so much. So instead, we brought the VR goggles out to the pre-op area. We put a set on the patient and a set on the family, and they were actually able to see why the change in plan was necessary and immediately caught on to the fact that this was the better way to do the operation. So if you guys want to go ahead and put the goggles on, we'll get started with our VR fly-through. You guys ready to fly? Let's do it. So instead of the DICOM images, you can immediately see how much more intuitive the 360-degree reconstruction of the skull is. My 5-year-old daughter looks at this and recognizes, yeah, the green thing's bad, right? You're going to take that out if I get one, Dada, right? So when we do a fly-through like this, the planned supraorbital craniotomy, as you can see from this point of view, we got a pretty good angle at the tumor, and as we kind of fly in, we're able to see the tumor and the optic nerves and why this patient was losing vision in the right eye. However, as we fly around a little bit and we take a look in the back of the orbit, you can see there through the superior orbital fissure, there's a tiny tongue of tumor hanging down behind the superior orbital fissure that I realized from the VR rehearsal I was not going to be able to get out through the supraorbital craniotomy. Fortunately, instead of making that mistake on the patient, I made a virtual mistake on the 360 model and was able to correct it. I said, you know what, let's try this again. Let's take another shot at it. Instead, we'll go from the side, from a terional craniotomy, and see if that gives us a better line of attack or better line of sight to take out this tumor. And so as we fly around the side and simulate the terional craniotomy, you can see the branches of the MCA riding over it there. And as we take a look from this angle, we're able to, after drilling down the sphenoid wing, see both the superior aspect of the tumor extending up along the intracranial fossa, but also the inferior aspect of the tumor. That was that little tongue that was hidden behind the superior orbital fissure. That was just something I didn't recognize from the preoperative planning stage using the DICOM images. Now maybe a more experienced surgeon, maybe somebody that's been doing this for 25 years would have immediately known, yep, I wouldn't be able to get that out. But this is how we get better at things. This is why we need to practice. This is why we need to rehearse surgery in order to continue getting better and figure out better ways to do things. So from doing this, bringing it out to the patient, they immediately were able to see, oh yeah, doc, that makes sense. It wasn't just a, well, I don't really understand what you're talking about, but just go for it. This was a truly informed consent. The patients have a better understanding of their own anatomy and pathology, and they feel like a part of their own healthcare team. So then we take that same technology from the preoperative rehearsal and planning area and engaging patients and take it into the operating room. You guys can take the headsets off now. We're going to go to augmented reality in the operating room. So we have integrated the 360-degree model And then using the stealth station navigation and the optics of the microscope, we're able to synchronize these three things together to make true augmented reality. So and this is injected into the ocular piece of the microscope. So as I look here at the microscope, go to passive mode, show me just the microscopic view. So this is the live optical image showing the branch points of the MCA and the tumor, which is here in white. You can see the tracking on the stealth station. Now if we go to synchronized AR mode, you can see the virtual overlay, or the augmented reality overlay, demonstrating the same vascular pattern and how precisely they match up. Just for the sake of demonstration, I'm going to touch the branch point here in the MCA, and you can see the probe coming in on the virtual model. You can also see that it's moving when I touch it there on the microscopic image. If we didn't believe that was an accurate overlay, we can turn on the yellow 560 filter and see the tumor glow up as if we had given sodium fluorescein, demonstrating the accuracy of both the AR overlay as well as the virtual 3D reconstruction, and giving us true augmented reality and additional information that we previously didn't have. Well, that's all well and good when we're here at the exhibition center and working on a plastic skull, but how does it work in the operating room? So let's take a look at a real case we used this for and how we used it to alter the surgical plan, and how the AR overlay helps us to perform the surgery with exceptional precision. So this is a case of another anterior cranial fossa meningioma. In this case, the patient had a very extensive frontal sinus. Now we all know entering the frontal sinus is part of the deal with supraorbital craniotomies. However, it's a pain. If we can avoid it, we'd rather avoid it. The risk of CSF leak in the fat graft. So instead of doing a traditional supraorbital, I used a pre-existing forehead crease, which I mapped out using virtual reality to extend the limit of the craniotomy to the superior aspect of the frontal sinus and not violate it. So here we're using, again, the synchronized AR, augmented reality, by using Bovie on the navigation wand to delineate the superior aspect of the frontal sinus. And then we can make our craniotomy just up to the frontal sinus to give us the most inferior access possible, still without violating the frontal sinus. So we make our keyhole craniotomy. Again, it's pretty standard 2 by 3 centimeter craniotomy. Here's ultrasound verifying the accuracy of the 3D overlay. And now we're looking at the microscope image on the left and the augmented reality synchronized AR image on the right. You can see the position of the optic nerves, you can see the position of the tumor and the vessels of the circular willis. And as we start to dissect along the base of the tumor, we're fading in progressively on the augmented reality. When we move the microscope, the augmented images move with it to track the position of the focal point of the microscope to give us Superman vision. And this allows us to see what we can't see in the operating room. And then as we focus, you can see the AR image adjusting according to the focal point of the microscope. This is again thanks to the integration of the stealth station, the Zeiss microscope, and the synchronized AR. As we dissect around the border of the tumor, cutting the arachnoid bands, you can see the accuracy of the overlay by as if we're bipolaring the bright green thing. In actuality, it's the tumor that's enhanced by the augmented information that's given to us from the synchronized AR. And as we continue to dissect around it, there's our nice arachnoid plane. And we've dissected around most of the tumor now. We're going to start to dissect up over the top of it now, using a series of ring curettes. And again, you can see kind of the augmented reality overlay on the tumor and how it's telling us exactly where the borders of the tumor are without me being able to see them. And we're able to remove it in a non-block fashion in a single piece. We cauterize the dura, drill out the bone a little bit, and get a Simpson grade 1 resection. And again, the accuracy of the tracking probe on the microscope with the AR. So this is the entire patient spectrum of using extended reality technology in the operating room, how we use it to plan and rehearse for surgery to make ourselves better by practicing it again and again, how we better engage our patients by having them a true understanding of the three-dimensional anatomy and pathology, and then using the same technology in the operating room to give us a better access and better visualization of structures that we can see and structures that we can't see in order to make surgery safer and more effective. This is what we're looking for in technology, and I think we've found it here. So that concludes, and I'll take any questions that you guys might have at this time.
If anyone has any questions?
If not, if you'd like to come up and take a look, we can demonstrate for you as well.
Yeah, please come out and try it yourself.
So you want to use